So today we're going to talk about obesity and breastfeeding, exploring the relationship. But one of the key things that I want us to do, thank you. So when I walk around, because I'm a walker, talker kind of girl. So when we talk about this, I want to make sure that we really learn about obesity. Okay, a lot of people think we know about obesity, but there's a lot that you don't know. And I find this when I talk to any group, whether it be a group of clinicians or whether it be a group of persons that are outside of the space of directly talking about medicine, that there's a lot that people don't know about obesity that we assume we know because, it really should be very simple, very easy. It should be about just, looking at caloric values and intake. So we're going to talk about some of that. We're going to lead into the discussion looking specifically at issues related to obesity and breastfeeding and the correlation, causation of those two things to make sure that we kind of understand where we are and where we need to go to make sure we understand what's going on here. So I have no disclosures to report, which means basically no one pays me money, that's what that means. But let's look at obesity compared to other diseases in the United States. And when we talk about obesity as a disease, it's important to recognize that it is a disease process. It is not just a lifestyle choice. One of the things that I often will write about in the literature is this issue or concept that obesity is a lifestyle choice, meaning people choose to have obesity, and I would say that that is not true. So let's look at what we have here. Let's start at the very bottom. We're looking at, let's say, HIV, colon cancer, and breast cancer. You can see that we're about 1.2 million in terms of prevalence in the U.S. in millions. We get into all cancers, about 2.8 million. We get into diabetes as we kind of go up this graph, getting into 13.8 million and 37.2 million. Here we get into non-alcoholic fatty liver disease. So we have 80.3 million people in the United States that struggle with that. And then we get into obesity, which is, of course, our topic of discussion today, about 91.3 million. Some of the current estimates kind of estimating us more at 93 million. Let's compare that to the number of people that own a TV in the United States, 115.6 million. So not far off there, just giving you an estimate of how common it is. And then this kind of number here is the number of people that own a smartphone here in the United States. So you can see that when we look at obesity, really compared to all other disease processes, that it is by far the most prominent, the most prevalent, and the one that we will spend most of our time dealing with regardless of what fields we're in. Now let's look at the prevalence in terms of male-female dynamic. Now these numbers are showing 2009, 2010, and these are the most recent numbers that were put out by NHANES, the National Health and Nutrition Examination Survey, which is done by the Centers for Disease Control and Prevention. So if you look here, we're looking at adults on the left side, right? So adults age 20 and over. You can see the numbers in millions, seeing that females are slightly more than the number of males at 40.6 million compared to 37.5 million. And children and adolescents, we still have very prominent numbers here, about 12.5 million. And children and adolescents are done based upon growth chart data. So we're looking at those that are still in several millions. And what we're seeing is a trend that's continuing, and we're concerned about that. Now, this is the concept that I always have to start off any patient visit if I'm dealing with patients or if I'm dealing with a presentation of really getting us to understand what energy balance is. So what we've heard all of our life is that it's really very simple. It's about how many calories we take in, meaning in terms of food and beverage, and how many calories we put out in terms of our body function, stool, etc., physical activity. So by a show of hands, I'm going to ask you guys, is this incorrect or if this is correct? So how many people believe that, energy balance is this is it? Raise your hand, just show of hands. Okay, so I have a few hands. I think some people are being shy. Remember, you have to vote. And I can see, because it's a smaller crowd than I'm used to, so I can see who's in here. And I will call you out. So a few hands. How many people think it's more complex than this? Okay, so a majority believe that it's a little bit more complex than this. And I would say that those majority are right. We're going to learn why this is not as simple as calories in, calories out. Because if it was really that simple for my patients, all I'd have to do is give them a calculator, give them a number, and they all should look like me tomorrow, right? Not really tomorrow, but still. Okay, so let's look at why that is. First of all calories aren't created equal. One of the things that I think frustrates me the most is our focus on caloric value as opposed to the quality of calories that someone is taking in. So on the left side of this picture, you see a picture of this kind of pepperoni pizza, highly calorically dense, very processed, on the order of about 350 calories, that one slice of pizza. To the right side of the screen, we have this, you may not see it, I don't know how it's projecting as well, but it's a quinoa, chickpea, roasted red pepper salad of some sort, probably in the order of about 700 to 750 calories. So with the idea of calories in, calories out really being, if we kind of look at it on the simple level, if I eat this, which I just told you guys was on the order of 700 to 750 calories, I should gain a significant amount of weight, but I should lose weight by eating this, which we know not to be the case because the body likes less processed. The less processed, the better. The less processed, my body is happier about communicating information to my brain, which tells me I don't want to eat, okay? So we'll talk about that. Now I'm gonna get technical for a while. You guys ready? I don't know if you guys are ready. Okay, I'm gonna get technical, but the reason why we're gonna get technical is because I really want you guys to understand this concept of how the brain regulates food and food intake, okay? I do this with every patient, no matter what their level of education is. I try to break it down, so we'll come to that. But first, when we look at obesity, it's important to recognize that it's a multifactorial disorder where genetics, environment, development, and behavior all come together to play a role in the likelihood that a person will struggle with weight, okay? Now, this is when we get technical. I was preparing you guys because I knew it was coming. Don't freak out. This isn't a science experiment, but I do have to explain this because this is very important in terms of us knowing how food intake is regulated in the body. So here we have this, it looks like just a diagram, and it looks like I'm going to do like a science experiment, but let's look at what's going on here. So we have the brain, okay? And so if I were to slice your brain down the middle, so just imagine I'm kind of cutting down. We won't do that today, but let's just say we did. We would get to this central portion here, which is called the hypothalamus. It looks like nothing is really going on there, but the hypothalamus is getting signals from the periphery, and by the periphery I mean out here in the adipose tissue. Adipose means fat. It's getting signals from leptin there. It's getting signals from the large intestine, the small intestine, the pancreas, and the stomach. And it's sending signals back via the vagus nerve and the spinal nerve to the brain, which tells my body, your body, how much we're supposed to eat and how much we're supposed to store, okay? You're like, gosh, that's a lot going on. So it's not this concept of willpower. The concept of willpower is like, I just tell my brain I'm going to eat less and that's what's happened. This, we can't tell those signals how it's going to signal. If it were really that simple, then I would be a billionaire and I might not be hanging out with you guys, but let's just say, okay. So let's move on. Okay, first of all, let's look at what all of those different kind of substances were. I just kind of want to explain what those substances are. And don't worry, some of this will sound technical, but don't you just hang in there with me, okay? Now, when we look at the substance of ghrelin, which you guys may remember being in the stomach is the production site, but then there's also neurons in the hypothalamus, in that portion of the brain that we looked at. And its effect on feeding is this orexigenic, which means that it stimulates your appetite. So people that have high levels of ghrelin have a higher likelihood of wanting to consume more food, okay? Now there's anandamides that happen in the small intestines. They're also orexigenic, which means they increase someone's appetite. We can't fix what that is in someone's inside of them. Now insulin, everyone's heard of the word of insulin. We usually think of insulin as the insulin that people give to themselves if they have diabetes. But what we don't think about is the fact that within us, all of us are producing insulin. We have baseline levels of insulin that help control our blood sugar. Now insulin, when it's inside of the body, not being administered externally, is anorexigenic. When we think anorexigenic, we think of something that causes us to have satiety. It promotes a feeling of fullness. So if we have good levels of insulin inside of our body, not being given exogenously, that promotes an effect on feeding that's anorexigenic. Now leptin, which we'll talk about in just a second again. Leptin is one of these very important hormones that's produced in the stomach and in the fat cells. It's the adipocytes. And it also is anorexigenic. So people that have better levels of leptin tend to have a better level of satiety, meaning they feel full quicker, okay? Now, these other two enzymes that we'll see, and we'll kind of revisit this, especially as we get into the breastfeeding data, cholecystokinin and peptide YY, which are produced in the small intestine and the large intestine, they are also anorexigenic, which means they promote satiety. Within each of us in this room, and anyone that you would see walking down the street, the differences in these can shift one person into having severe obesity, one into having a very lean figure. And so it's important to recognize the role that each of these play. Now, this is my favorite slide. It may not be your favorite slide, but it will be in just a second, okay? We talked about that leptin, which was one of those really important hormones. And I guess I should come over here. I don't want you guys to feel neglected. I'm coming back over here. So if leptin is in the body, it's a hormone that we know is anorexigenic. promote satiety. It can bind to this receptor. Kind of think of this as a lock and key mechanism, okay? We're gonna focus on this right side of the pathway. When it binds, it stimulates this neuron in the brain. It's called the POMC neuron, which, to make me sound smart, I can say the pro-opiomelanocortin neuron, but we don't have to worry about that. When this binds here, it stimulates what's called an anorexigenic signal in the brain. An anorexigenic signal is stimulated, and these people have high levels of what we call brain-derived neurotropic factor. For those patients or people, those people tend to be very, very lean. I like to bring up my husband right about now because he gets a signal in his brain, we've been together for 22 years, that just really tells him not to eat. I can talk to him at 8 o'clock p.m., because that's about how late I might be leaving work, and say, well, what have you eaten today? And he'll say, oh, I haven't done that. And he really just does not remember that he isn't. He's not telling himself that I don't want to eat. He's not saying, I'm going to be on a diet. I do not want to eat today. He really just does not get a signal that tells him I am hungry. So he likely has very high levels of this brain-derived neurotropic factor. This side of the brain is firing, which tells him not to eat, but also not to store once he takes in food, okay? So let's look at the alternate pathway. I only see patients that struggle with weight. They can normalize their weight within my care, but I only see patients that struggle with weight. They signal likely the alternate pathway where this locking key mechanism looks the same, but it stimulates a different neuron. Think of that neuron in the brain is firing, is giving you information about what to do. This is called the agouti-related peptide neuron. When this fires in the brain, it produces an orexigenic signal, a signal that tells my body not only do I want to eat, I want to store. So do you guys remember that chickpea quinoa salad that we had earlier? Well, we didn't have it, but we looked at it. So two people, let's say myself and one of my patients that struggled with severe obesity, we might sit down to have that same meal. My body might decide it wants to hold on to, let's say, 22.4% of that meal, whereas their body sees normal as 300 pounds. Their body might decide, you know what, in order to maintain that 300-pound weight set point that I have, my body needs to hold on to about 86.4%. It's not that we did anything differently. Our bodies just determined there was more energy that needed to be retained in that patient than myself. And it's not that I'm better, it just means that my body processes things differently, okay? Now let's look at this fetal programming, the concept of fetal programming. And this means that if a mom goes into pregnancy with excess weight, overnutrition, obesity, she then predisposes the fetus to that inflammatory state. Okay, so a woman that has obesity or what we consider overnutrition has increased inflammation, increased resistance to insulin, increased breakdown of cholesterol in her body. When that happens, the fetus, which is in utero, is exposed to lipids, fat. And what that does is it increases fetal inflammation and leads to childhood disease. So even when you control for genetics, a mom that has this going into pregnancy is going to predispose the fetus to increase lipids, which then increases their likelihood of having fatty liver disease, obesity, hyperphagia, meaning an increased desire to eat, diabetes. And that is problematic. When we look, for example, at African-American women, as you guys can tell, that's what I am, 80% of African-American women are either overweight or obese here in the United States. If that is indeed the case, which we do know it is, we know that the likelihood of a child that is of African-American descent having obesity is much higher before we even look at all of the other things we're going to get into today, because that mom's intrauterine environment has already predisposed that child to obesity. So the first 1,000 days that I know we'll be talking about, those things are almost, we're behind the 8 ball by that point. We want to get them prior to conception so that we can influence the likelihood that this child will not struggle with obesity. Now, this kind of gets into this kind of concept of fetal programming and how important a mom's status going into pregnancy is in terms of looking at the likelihood that a child will struggle with weight. So this is an article looking at a prospective study, so meaning going forward, a study looking at children that were born to mom and dad dyads, meaning the same mom and dad. And these are women that have undergone weight loss surgery, specifically in the form of a Roux-en-Y gastric bypass. This BMS means children that were born before maternal surgery, meaning before she had surgery. And then the AMS means after maternal surgery, so after the mom has undergone surgery. Same mom, same dad, but we're looking at the children that are born pre-surgery in the children that are born post-surgery. Keep in mind that children or moms that are qualified for weight loss surgery have severe obesity, okay? So let's look at this. I'm coming back over here, you guys, because I need to walk around. It's one of those things I have to do. So let's look at these. So we're looking at these children. And what you can see that overall kind of they're similar in terms of gender, these children that are being born to these moms before and after surgery. Let's look at the differences in the birth weight. So those that are born before maternal surgery, and this is in kilograms, weigh significantly more than those that were born after maternal surgery. Remember, same mom and dad. Macrosomia, meaning having a child with a large body, much higher likelihood compared to those that were born after surgery. We expect a difference in age, right? Because these are born after surgery and these were born before surgery. Let's look at the body mass index percentiles, and this is done based upon growth charts. You can see that we have significantly lower BMI or body mass index in those children that were born after surgery. Their weight is significantly different, body fat percentage different, insulin levels much lower, glucose lower. Same mom and dad, but what we're seeing is a difference in that child that was born after surgery without modifying any genetics, okay? Now, what we see when we kind of look at this in great detail is that when we compare children that were born to the same mom and dad group that were born before surgery versus after surgery, we have a threefold decrease prevalence of severe obesity in those children that were born after maternal surgery. We have increased insulin sensitivity, an improved lipid profile, meaning improved cholesterol profile in those children born after surgery. We have decreased CRP, means C-reactive protein, which is an inflammatory response that we talked about in that fetal programming slide. Decreased leptin, increased ghrelin. So what we're seeing overall is that there is an improvement in these children that are born after surgery. Now, when we look at the central nervous system, kind of just to bring this all home before going into specifically the breastfeeding data, we see that the brain plays a significant role in how weight is regulated. The quality of the diet is important. That's what this stands for. We're kind of here. Physical activity is important. But I'm going to give you guys a multiple choice question and pretend like you guys have clickers. So what is physical activity specifically good for as it relates to someone's weight? Does it either A, does it typically increase a person's weight over time? Does it B, cause someone's weight to be maintained? Or does it C, cause a decrease in, decrease in weight? So A, for those people that think that physical activity increases weight on average. Okay, what about B, causes it to maintain weight over time? Okay, and what about C, causes a decrease in weight? Okay, there are a few. Okay, so you guys are doing pretty good. I'm proud of you guys. So it usually causes a maintenance of weight. So if we look at people that work out today, and follow them for 10 years into 2026. On average, their weight will be more maintainable. But the thing you don't hear about when the gyms are advertising at the beginning of the year, come join our gym to maintain your weight. Okay, that's not going to sell that well. They have to say, come join the gym to lose weight. And do some people respond to physical activity with weight loss in the acute period? Absolutely. But if you look at them 10 years later, 20 years later, on average, those people that are in the gym kind of look about the same, right? Let's look at that. Now, sleep plays a large role in weight regulation. Medications that I can prescribe to you or prescribed by your physician can cause significant weight gain. I've seen in excess of 180 pounds with certain medications that are prescribed with no change in caloric value or physical activity, okay? Circadian rhythm disturbances, meaning those that are night shift workers, tend to have more weight. It's not that they're eating more. Everybody's like, oh, the night shift workers do eat horribly and do these things. Their brain is upset that they have to work night shift. The brain wants to be asleep when it's dark outside. It wants to be awake when it's light outside. And when we deviate from that pattern, which we often have to do in healthcare because people kind of get sick in the middle of the night and babies are kind of born in the middle of the night. There are things that kind of we can't control. That, though, shifts their weight significantly. And this is not metabolism here. This is baseline thermogenesis, meaning how much my body burns at rest and with activity. So, for example, I'm going to go back to that African-American woman. On average, we know that African-American women burn less at baseline compared to Caucasian women. We don't know why. We're learning why, but we do know that there is a significant difference, and that's been in every single study that's ever looked at thermogenesis levels, meaning ability to burn at baseline for African-American women here in the U.S. compared to Caucasian women, okay? Now, this is a funky slide, but this is one of my favorite slides because this captures why this kind of concept of obesity is way beyond this calories in, calories out mantra that we've heard for so long. These are all the potential contributors to obesity that we know of as of today. And so let's look at it. So we have all of these things that are happening inside of the person, all of these things that happen outside of the person. These things at the very top lead to increased intake, meaning increased ability taking on calories on board, okay? These things here at the bottom, decrease expenditure, decrease ability to burn, okay? And then these things in the middle, which is kind of this most robust area, can affect both intake and expenditure. Now, these different colors on the screen are different contributors or influencers to weight and weight regulation. So these things here in the purple, right here, these are environmental pressures on physical activity. In this kind of lavender color, biological or medical reasons why someone might struggle with weight. Here, very, very important, you can see this big yellow area. These are maternal or developmental reasons why a person might struggle with weight, meaning how the mom's nutrition and or developmental state was prior to conception has an influence in the likelihood that a person will struggle with weight. In the pink here, we have economic reason, food and beverage behavior and environment here in the orange, psychological in this kind of teal green color, and then social here in the blue, okay? So you can see that it's much more robust than we'd like to think. And I like to bring up a kind of a boxing analogy, and this is interesting because obviously Muhammad Ali just passed, but this is typically how I bring it up if I'm talking to patients. So I think of us as like putting you into like a boxing ring with like Muhammad Ali at his height, like when he was like fighting against persons like Joe Frazier. And I might put one person into the ring, and all it takes is me throwing in some age-related changes like menopause, throwing in a little stress, and maybe having some food surplus. And those three things are the things that knock them down, meaning push them into obesity. All they need was 3 punches, and Muhammad is taking you out of here, okay? Now, someone like me, I still, as a human, because that's what I am, as a human, have a likelihood of developing obesity, but I might be able to go a few more rounds with Muhammad, meaning it might take 2 of those things, 3 of these things, 4 of these things, 5 of these things for me to develop obesity. I still have a predisposition. It just takes more for me to get there, okay? Now let's talk. We're focusing now specifically on breastfeeding and what's going on in terms of initiation, continuation, exclusivity with breastfeeding when we look at it by weight status. So this is a study that just came out last year. What you can see here is this is normal weight kind of in this like dot, overweight, obese categories 1, 2, and 3, and this is done by BMI status. And so let's look at, this looked at over 200,000 women. It looks at the initiation of breastfeeding. So what you can see is that normal weight individuals, not only do they have a higher likelihood of initiating breastfeeding, they have a higher likelihood of continuing it and have a higher likelihood of making it exclusively their source of nutrition for their infant, okay, as opposed to using, let's say, formula feeds to substitute. That was continued from 2004 to 2011. So they've looked at this over time. And what you can see is this upward trend where normal persons that have normal weight by BMI status always tend to be superior. And as we get further out into obesity categories, we have a lesser likelihood of initiating, continuing, and being exclusive breastfeeders, okay? So this is looked at 12 weeks postpartum, okay? Now, in that same study, the study we were just looking at, they looked at the adjusted odds ratio for continuing breastfeeding by weight class. And this is important because you can kind of see this probably a little bit easier than you could see in the previous slide. So this is the odds ratio of continuing breastfeeding or initiating, continuing exclusivity. And you can see that the normal weight counterparts are, this is normal weight, okay? And we're looking at that and comparing it to persons that have overweight or obesity. And you can see as we trend down to those higher levels of obesity that we have a lesser likelihood of dealing with a woman who's initiated, continuing, or exclusively breastfeeding by weight class. So we can see that there's some differences. Now, are these differences associated with their body habits that makes it somewhat different or maybe more challenging to breastfeed? We're not sure. These are just the trends that we're aware of. Now, this is, I think, very, very important. And I know a lot of our focus, specifically within this setting, is looking at the role of race and ethnicity and breastfeeding and what that means, especially since we know ethnic minorities have a higher likelihood of struggling with obesity. So this study that just came out, this is hot off the presses, May of 2016. I tried to give you guys data that's very current. You can see here that when they looked at, this was, I think, about 70,000 women, they looked at breastfeeding analysis by body mass index score. And what you could see is that on the population as a whole, and this is a significant p-value, anything less than 0.05 is significant. On the whole, it appears that breastfeeding does help with weight and weight modulation. But let's look at it with a fine-tooth comb, okay? So if we're looking at non-Hispanic whites, it's significant. But then when we look at it with non-Hispanic blacks or Hispanics, we see not so significant. So that kind of gives us some pause. Why is there a difference in how breastfeeding affects, let's say, the Caucasian population versus ethnic minority populations? And I think that's a question that begs to get answered that we really don't know the answer to. Now, in this particular portion of the same study, they looked at overweight and obesity of an offspring by the age of 4 by race and ethnicity. So overall, we see that breastfeeding seemed to decrease the likelihood of overweight and obesity by the age of 4. But what we see is that it's much more prominent in the Caucasian population. We do see some significance here in the African American population, but here again, Hispanics are not showing any benefit. Still, what begs the question, why? We don't know. May 2016, so very fresh off the presses. This study came out in June 2015 in Breastfeeding Medicine, so I'm happy for you guys publishing great data. And this looks at the prevalence of breastfeeding by race, ethnicity, by maternal pre-pregnancy BMI, so how much they weigh prior to going into pregnancy. And this looks at persons that fall in the underweight category, normal weight, overweight, and then have obesity. This is drawn out by class. So white non-Hispanic would be this first bar, just to kind of give you guys an idea. Black non-Hispanic in this second bar. Other, meaning non-Hispanic, but others fall into this category, and then Hispanic. Now, what you can see across the board, if you guys just kind of look across the board from underweight to those that have obesity, is that African American women have a high likelihood of non-initiation of breastfeeding, no matter what weight class they fall in. You guys can see that very prominently. As, of course, we go up, you don't see significant variation. Actually, in this overweight category, you actually see a higher level of non-initiation than actually going up the weight class. Let's follow that by white non-Hispanics. We do see non-initiation relatively high in this underweight category. But, you know, as we get into these persons that have obesity, we can see that increases. We see less variation in others and then the Hispanic population, but we do see a higher likelihood of non-initiation, for example, there. But this just bores out, that shows you, for example, and I'm coming back to my people, that we just tend not to breastfeed no matter what size we are. Why? Is that culture, like you brought up in your question before? Casey, I think, brought that up also. Like, what is it? I don't know. I don't know what that is, but you can see it bore out in the literature. Oops, there's some missing slides. There's a few missing slides. Well, I know what's supposed to happen after this. So basically what we've seen here is that there's some data that kind of is conflicting. There was another slide that was going to come up that talks about the differences in breastfeeding internationally. And what we saw in this international study comparing different countries as that there's differences in breastfeeding initiation by country that doesn't really help us explain the variation in size. So for example, in India, low levels of initiation of breastfeeding. Indonesia also. When we look at that and compare that by body mass index, does that really give us all the information we need to know about directing breastfeeding in these different countries throughout the world, and how that will lead likely to a lower likelihood of having obesity? We don't know. When we look at meta-analyses, meaning pooled data, overall, we see that as we increase our likelihood of breastfeeding, rates of obesity go down. But then when we go back and look at it with the fine-tooth comb, not seeing that as much bore out within the African American and or Hispanic populations. So there's a lot of information we don't know. Now, there was one study that was included in my slides that somehow aren't. Oh, wait a minute. I'm getting slides. Okay, well, that's. I'm glad I remember. You guys know that I knew my slides. I was like, I know what's coming up. I was like, that's not okay. Well, so okay, let's go back. Okay, okay. Woo. But I'm glad I remember my slides. Let's go back. Okay, here we go. So out of order. Yeah. Okay, that's what's going on. Okay, so we're gonna pretend like. Okay, we're gonna. So you guys already knew this already. So let's look at this. This is that meta-analysis that I was talking about. I'm glad I knew my slides. This is looking at breastfeeding duration. So persons that breastfeed less than 3 months, 3 to 4.9 months, and then going up to those that breastfeed greater than 7 months. And so what you can see is a dose-dependent relationship. First of all, these are the number of studies that were included in this meta-analysis that was put out in 2014. But you can see that the likelihood of having obesity associated with breastfeeding duration is such that those that breastfeed longer have a lesser likelihood of having obesity when you pool together these studies. This is the country data that I was talking about. So if we look at countries, an international evaluation of breastfeeding at BMI at age of 6 or 7, you can see here, India, which was what I knew off the top of my head. People in India that tend to breastfeed tend to have a higher BMI for these children at the age of 6 or 7. Whereas, let's look at Spain, lower, lesser likelihood. You might say that, Dr. Stanford, but there's more dots on this side. So maybe there's overall breastfeeding leads to a decreased BMI. If this is 0, that means decreased BMI. This means increased BMI. But we still have all these countries over here, Indonesia, India, Portugal, that when they breastfeed or when we see them women breastfeeding, that there's a higher BMI correlation when we're looking at that. So we can see that there's variations in different ethnicities, different countries, different races that we don't really have the answers to as to why this happens. This came out in pediatric obesity. Now, this is the hormonal changes that we see. This is, I think, one of the probably better done studies that I've seen. It's so new that it's not, you can't even get the citation information. It literally just came out last month in the European Journal of Nutrition. And this looks at those hormones that we looked at pretty early, and it looked at whether these hormones vary in breastfed infants versus those that aren't breastfed. So what we can see here is that ghrelin, remember ghrelin was that thing that stimulates appetite, it makes us want to eat. Ghrelin levels are much higher in those children that are formula fed versus breastfed. Also leptin, remember that's one of those anorexigenic hormones, higher. Insulin levels higher. GIP, PP are also higher. The only thing lower here is peptide YY, which we also talked about. But what this did was only look at these children up to the ages of 3 months. But what they're trying to do is determine how breastfeeding is really affecting things more in the pathophysiology level instead of us just doing correlative studies saying, oh, if we breastfeed, then this leads to decrease in obesity. I think I have to go backwards since they're out of slide. Okay. Yes, this is what should be the next slide. All right, so what we've kind of determined is breastfeeding is linked to many health benefits in mothers and infants, but the role in postpartum weight management, meaning for the moms, is unclear. When we look at systematic review of 37 prospective studies, meaning studies going forward, and 8 retrospective studies, most of them show little or no association between breastfeeding and weight change. But of the 5 high-quality studies in that group, 4 demonstrate positive association between breastfeeding and weight management in those moms postpartum. But we do need more studies to assess the impact of breastfeeding on postpartum weight management. A lot of people do think of using breastfeeding to control weight in moms postpartum. So basically, how I'm going to conclude is the following. It's unclear whether breastfeeding plays a role in obesity in offspring and weight retention in mothers, but we do believe that overall breastfeeding has a likely positive impact on weight regulation in the mother and offspring. We just can't definitively state that. It does affect appetite regulating hormones, which you guys saw on that slide. And more studies are needed to really clearly define the role of breastfeeding in this obesity epidemic. So I think that this is really an idea or concept of we really need to get funding to really look at this more with a fine-tooth comb. Not let's just look at it through a lens of epidemiology, but let's look at it through a lens of really determining how breastfeeding really influences obesity beyond just doing correlative studies. So I want to thank you guys for your time. I'm open to answering any questions as it relates to obesity, weight regulation, and breastfeeding at this time. So thank you guys. All right, Casey's coming up for a question. I just happen to know your name. Casey, what's up? Casey's from Rochester.
Yeah, you can't get rid of me.
I'm ready. I'm going to put this down.
Thank you so much. First of all, I'd like to know how you get all this data before anybody else. It's brilliant.
It's the Harvard witness.
Yeah.
They would want me to say that. But
I figured.
no.
Yeah. So one of the things that I was wondering if you could comment on is so the work that Zoo does out of Texas. He has a really interesting study on the anthropometric changes that happen and how breastfeeding sort of relates to a mom who has a very high risk. So the mom prenatally having obesity or and the effect on the anthropometrics of the child. And one of the studies that he did looked at the role that breastfeeding plays in interrupting the cycle that you brought up at the beginning. And I wondered if you could fetal programming, right? And so that possibly instead of these large epidemiologic studies that show, well, here it has an effect, but kind of in these countries it does, in these countries it doesn't. If we just look at the high risk moms and the role that breastfeeding can play, which of course from a public health standpoint brings up all of the issues that the high risk moms often have a harder time getting the breastfeeding education, feeling comfortable with breastfeeding, have body issues related to breastfeeding, and so forth and so on. So I was wondering if you could expound on that a bit, because I'm sure you have a lot to say about it.
Yeah, so I think, one of the key issues that, Casey, you've brought up is that one of the things that I feel like a lot of studies don't really do is focus on really those high risk moms. Okay, so those ones that have class 2 or class 3 obesity, and what that means. Class 2, I should have maybe put that up. Class 2 obesity are those that have a body mass index of 35 to 39.9, and those that have class 3 obesity have BMIs of greater than or equal to 40. Severe class of basically qualifying them for an intervention to the degree of, like, let's say a weight loss surgery. What we do see play out, and I think this is important, because obesity by itself is based upon these BMI criteria that were defined by the World Health Organization. It does not give us information about these anthropometrics. So people that carry central adiposity, meaning weight here in the midsection, or have a much higher risk, even if they have obesity, than someone that carries more gluteal adiposity. Gluteal meaning kind of hips, butts, thighs, okay? Really, that's kind of really what it is. And so what we are seeing in his data is that anthropometric values, meaning especially central adiposity, decrease in those moms that have breastfeeding, but also decrease in the children, which then decreases risk of major disease and illness that happens when we carry this adipose tissue in this area, specifically, which you guys saw in that initial slide of mine, that non-alcoholic fatty liver disease, which really is driven by this adipose or fat that's carried in the midsection that's really surrounding itself around the liver. So what I think that when we're looking at studies just outside of this correlative data, that we do need to look beyond this concept of just obesity, but look at the likelihood of cardiovascular risk factors. And obesity in itself is, but when we're looking at things like type 2 diabetes or fatty liver disease, those things are directly impact the longevity of a person and the quality of life that the patient has. And so I think that when we're looking at studies, we need to look at obesity, but look at kind of these sub-analyses of really looking at how does this impact those other disease processes that are so prominent, specifically type 2 diabetes, non-alcoholic fatty liver disease, because those are driving mortality rates down in those populations. So,
and then how many hits, right? So in your graphic, how many hits? Like, can breastfeeding add resilience?
And what's really interesting, if you guys couldn't, I don't think you guys could see that slide. Breastfeeding, as I know all the little dots in there, breastfeeding in and of itself is not actually on that slide. Because I think there's no, when we look at it, or the Obesity Society kind of put that slide together, we can't definitively state that it affects intake or expenditure. Whereas if we're looking at something like gut microbiota, which is the concept that a person that is lean tends to have more favorable gut microbiota, meaning bacteria that then supports better weight regulation, we do have data that definitively states that. And so I think, will that make it into the graph at some point? Maybe. Will it make it into the graph with some asterisks, meaning like we do see it bore out very strongly within the Caucasian population, but not in maybe ethnic minority populations? Maybe. But what you do see, if you look at those yellow, which was that whole area looking at maternal and developmental influence of weight and weight regulation, is that we haven't definitively kind of made that conclusion. Now, that meta-analyses, which was pulling together all of those studies, did overall show this trend towards a decrease in weight and weight regulation, but that was more of a correlative versus causal. And so I think that's really important. Hopefully that helps. If not, I'll stay around and talk. Any other questions? I see someone coming up. It's exciting. I'm excited. I like to talk, so this is great. You guys didn't figure that out, right? And tell me your name
Good
and where
morning.
you're coming from.
Michael Young, Howard University.
Oh, fabulous. You're just around the corner.
Right around the corner.
Okay.
So when I look at the literature, we allude to the control that the infant has at the breast, and they limit their own feeding. But is there anything that in any study that actually measures that and that impact?
Can you, I'm not completely
So
clear.
when the
understanding
baby
your
breastfeeds, he decides how long he's going to breastfeed. When he's full, he's done. And so that infant is controlled, as opposed to being a bottle-fed infant that's going to kind of get overwhelmed and is going to drink whatever flows out. So that the programming is to overeat from the beginning. But I mean, we make allusions to that in breastfeeding conversations, that's how that breastfed infant learns to, they have control of their own feeding. But anything that measures that.
Yeah, so I don't. If you look at the literature on breastfeeding, there isn't any study that I'm aware of that really looks at the length of breastfeeding and whether that correlates with like feeding control in infants. I really think we still have to go back to that slide that I pulled up. Hold on. This slide, where we're looking at those appetite regulating hormones and those exclusively, formula fed infants versus breastfeeding infants. When we look at just the molecular level, looking at these hormones, we do see, and let's just focus on ghrelin at the top of this, because that's probably the one that it makes the most sense. So if we look at ghrelin, which we know stimulates appetite, the formula fed infants at baseline have higher levels of ghrelin, which tells them they want to eat more. So is it really that they're eating more because they're formula fed, or is it that their body's already telling them to eat more, and so then they get more from? Does that make sense? I don't know if that's making sense. So that's I think important. And I think that's why when I saw this study, because I was really fine-tooth looking through the literature, and I know Carla was going to be like, what's the latest data? This is the latest data, but there's so much that we don't know. But if we had a study that was more robust looking at this and maybe correlating it with length of feeds from breastfed versus formula-fed infants, we might see some difference. But what I'm seeing here at baseline is something that's very strong, that those formula-fed babies tend to have higher levels of ghrelin, which tells them, hey, I want more at baseline. Maybe that's stimulated by the fact that we know, and we saw on those slides, that persons that have obesity are more likely to formula feed, which means their children are more likely to have higher ghrelin levels at baseline. Does that make sense? Volume of intake in terms of the feeds? No. So I've not seen that per se. And I think that's what I'm saying, that we don't know that. But we just do know that if we're looking at ghrelin, which is that orexigenic hormone, that if their levels of orexogen, which tells my body, because they can't, here it is, let's look at babies, they really can't tell you, I would like to restrict my intake today. I'm going to, their brains just, they're at the lowest level of intelligence with regards to that. They just do what their body tells them to do. If their body is telling them, I'm hungry, I'm going to cry, which will demand a feed, which will then be a formula feed, and yet I have more volume, then that will likely trend their bodies up, okay, in terms of weight. And so that's something that they can't tell you. They can't tell you, but they can demand a feed, and they know how to communicate with whomever their caregiver is to say, I'm hungry, I want feeds, but that's driven by how their brain thinks about it, okay? And so I think that's important, whether or not the volume of the feed, whatever the volume of the feed is, if it's in the newborn period and it's 2 to 3 ounces, or if it's more as they get older, it's still being driven by what their brain is telling them, which is, I'm hungry, now, feed me, which is based upon these hormones, which are also telling them, I'm hungrier than this leaner individual. Yes? Mm-hmm. Okay.
Do you want to talk about that? I had to comment on something different.
Did you want me to comment on Kay Dewey's work? Was that what you said, Kay?
Yeah, well, because that's the one that you
Well, Kay Dewey, who is probably well known to all the breastfeeding community, has done many studies in San Diego, and she took a group of successfully breastfeeding women. They probably were all Caucasian, although it was not pointed out in the article. And at 3 months, the babies are feeding well, gaining well, and so forth. They tried to force them to take more. After every feeding, the mother was instructed to keep the baby at the breast and so forth. And they looked at these children for a month. And
After this force feeding time frame, or this encouragement. I don't want to say force feed this.
Yes, after a month of this encouragement,
Yes.
the babies did not take one drop more than they had been taking. And they looked at various aspects. They felt leptin was not an appetite stimulating hormone.
Well, we know it's anorexigenic, so it causes us to eat less.
Yes.
Yeah.
Right. Well, but what they thought about was the way babies breastfeed and some of the anatomical aspects of it. But we have always said, following this work, that you cannot overfeed a breastfed baby. And
Oh, you're gone. It was good. That was a great conclusion statement. So you can't. Oh, I love that. So she's saying that you can't overfead this breastfed baby, but the breastfed baby is getting a lot of benefits that the formula fed baby's not getting, right? So the breastfed baby has the whatever their level baseline appetite regulating hormones are, but they're getting so much more from the breast milk and from that connection between mom. That we just cannot duplicate within the formula-fed infant. And so there's likely a lot that's happening beyond what we're seeing here that we just don't know yet. But overall, that's why my conclusion statement, which was out of order, but my conclusion statement says that overall, I think we do have this trend showing a positive relationship, but we just need to learn what that really is, like what on the baseline level explains the differences that we're seeing, why that breastfed infant's like, I'm done. But they're getting that something in their brain is saying, what we see here is they're done. Yes.
well, and Kay did feel that it was the satisfaction of suckling at the breast,
Right.
as opposed to this mechanical.
Absolutely. It's very different. I mean, it takes a lot of work on the part of mom and infant, but it's a different mechanism. It's different. I mean, everything is different about it. And there's a lot of differences that, but even if you're explaining, I think Casey brought up those that are getting breast milk from a bottle as opposed to being actually breastfed. There's likely some differences there. And how do those bore out? And what does that mean? And that may help us with the fine-tooth comb determine this information.
Part of Kay's study was the third group that got breast milk in a bottle. And they took a little bit more.
But see, so there's some difference there. And so I think that you have to kind of look at the whole thing. And so that's exactly what we're saying. But what is it? What is it these hormones? Is it what? There's more to the story than what we know at this time. And I think this is exciting, right? It means we're at an exciting point of recognizing that there's things that there's a lot that we have to learn. There's a lot that I don't know. There's a lot that we just don't know. And it's exciting to see where this will come out in the literature and see what we find out. Absolutely. Yes. I'm sorry for having you wait there.
I had to defer to Dr. Lawrence especially because her comment was related to what you had just been talking about. I was going to say something about a different part of your slide set.
Okay, I'm ready. Let's
yes.
go.
So I was interested in hearing more about your thoughts about the weight control postpartum, because pregnancies are often an opportunity for women to go from being normal weight to overweight to obese to very obese to really, really obese. And I mean, undoubtedly, who is subject to that is influenced by all of your elaborate hypothalamic biochemistry that you laid out. But once that happens, it sets up a vicious circle, because a woman gets somewhat obese and continues, and then with each subsequent child, that baby's and child's risk of obesity and all the negative consequences you talked about would go up and up. And
Absolutely.
I was just wondering if people had looked at that and at the benefits of breastfeeding, especially for those women or for women whose mothers or aunts or sisters had that sort of ladder of obesity related to pregnancies, because they could potentially benefit even more than other people from the weight control, if
Absolutely.
not weight loss, postpartum.
And I think that's very, very important. What unfortunately you end up seeing in the studies that are out so far is that the women that are likely to breastfeed for weight regulation purposes are those that tend to be leaner moms. And so they're helping to control their likelihood of having this postpartum weight retention, using that as one of the tools that they utilize to help control weight, kind of this uptick in weight. But here we go. I mean, you saw, like, when we looked at breastfeeding initiation, continuation, exclusivity for women that carried significant weight, that as we moved up those weight classes, I mean, the drop off was it was definitively dramatic. And so what you see kind of study after study is that we're having some difficulty in getting those moms that really struggle with weight to consider this as a modality to help regulate weight in the postpartum period. I think that there's barriers that we have to overcome. Some of them are like cultural barriers that we might have to overcome. When we're looking specifically, I told you groups that struggle with, African-American women by far have the highest level of obesity rates in our country. But when you talk about breastfeeding within that community, or in my community, it's something that kind of people turn their nose up to. It's like, who's going to do that? And so I think there's so many barriers, and I think someone talked earlier about like needing to work at this on the local level and recognizing that there are things that were in that community. If we're dealing with a community based at Howard's Hospital here versus where I am at Boston, it's going to be a different approach that needs to happen or ensue to really get those moms to reconsider it. But it's going to need to be targeted at these at-risk moms. And so that's what we're seeing consistently in the literature. But I can tell you that in my clinic setting, most of who we see in the clinic setting will be women. About 80% of our patients at Mass General's Weight Center are women. Most of them are perimenopausal or postmenopause Caucasian women. But one of the things that you see, even when you're seeing, Caucasian women versus African American women, is this dramatic influence of postpartum weight retention on this up trend of weight,
ladder.
and then menopause being another big hit. Because if we look at women's lives, the three major hits that we look at, which we can't control, is the onset of menses. You see a lot of people have dramatic weight increase. Some people stay normal. Then some people get to pregnancy, and then we have this dramatic increase. And then you have this other set that, everything was fine, and then menopause happens. And so basically that's really what it is. I'm just trying to kind of, because when I'm spending that hour with them for their initial appointment, I'm trying to figure out which things in their lives influenced where their weight is now and how we have to intervene. And so I think that what you're bringing up is so important. And my goal when I go around the country doing whatever talk I do is to get people to think outside of the box and think of how they can influence it. I don't expect everyone to give me the next study that I can put up in my slide, and I can only do so many studies myself. But I do want us to start thinking outside of the box and stop just blaming these patients that struggle with obesity for their issue and their disease, and helping them to overcome it and influence the next generation that is to come. Because if we keep continuing up in the trends that we're dealing with, no one's going to be able to pay for healthcare at all. We just aren't going to be able to. It's just too much being spent right now on obesity-related illness. We see 93 million people. So I think you have great.
Well, and I was just going to say, from the point of view of those of us in the in the breastfeeding promotion community, from either a public health standpoint or a clinical standpoint, we can start including messaging like that and target
Absolutely.
more intensive interventions to women who have those kinds of risks.
Absolutely.
As a way of hopefully breaking that cycle.
Oh, I think that it'd be great. And if we could see great prospective studies in that realm, amazing. And then pooling together, everyone's resources. So what's going on in Atlanta being pooled with the resources here in DC or Los Angeles, and pooling these things, recognizing that the interventions may be different, and we don't really care as long as we're able to influence change.
Yeah, the biology is probably pretty much the same.
Absolutely.
So taking
Absolutely.
different approaches is good.
Absolutely. Thank you so much
Thanks.
for your comment. I really appreciate it. I think this is maybe the last one, maybe. Tell me your name.
I'm Amy. I work for ASTO, the Association of State and Territorial Health Officials. There
Okay.
we go,
Okay.
just so
Wow.
everybody knows.
Okay. Absolutely.
So one of my big questions is you mentioned a lot about the ethnic minority community, especially African American women. Have you done studies, because we all know that when you're breastfeeding, your appetite just drastically increases because not only are you having to feed yourself, you're having to now supply half that nutrients to this baby, right? So have you seen studies, or have studies been done showing that a lot of ethnic minority women live in communities with food deserts? So not only is it hard for them to maybe get fast food, but it's also hard for them to get basic nutrients, right? So how does that impact their actual initiation of breastfeeding, their continuation of breastfeeding, and then how does that change in appetite for them? Kind of have them think about, well, if I'm breastfeeding and I'm so hungry and I'm already obese and I know I'm overweight, maybe I'm going to actually gain more weight by my new intake of food while I'm breastfeeding this child. So is there a correlation with any of those things? Have there been studies to show that?
Yeah, so I hear what you're saying. I appreciate your question. One of the things that I would caution against in a study like that is this idea of correlation and the focus on just the food. When you talk to, this is just, being actually truthful in my dealing with people that struggle with weight in the African American community, many don't see their weight as problematic. Even if they've been informed by their clinician that they struggle with obesity, I've been told by individuals, not usually in my clinic, because people are coming to the weight center, so they know what I do. But if before I did what I do, which is when I did general pediatrics and general internal medicine, often if I brought up issues related to weight and weight regulation to people that or from my community, they were like, "Well, I'm fine," because they see their weight as normal. They see me as skinny. I'm normal, but that their shift of what they see as normal is such that I fall outside of the realm of their peer group. So I'm abnormal and they're normal. So getting them to even come to this idea or thought process that, hey, I do struggle with weight is a big challenge often, even from someone that looks more like them. So I'm telling them they're kind of like, I remember doing a patient visit, and I went in, I was actually in the emergency room covering a shift, and I was going through pretty quickly because you have to talk fast in the ER, and I talk fast at baseline anyway, so you can imagine what I'm like in the ER. And I was going through the history for this woman, and I was asking her just like her family history and like things, do you have obesity in your family, blah, blah, and she didn't really answer, and so I was like, okay, whatever, diabetes, blah, blah, just kind of going through the list. And then she came back to me and she said, you keep on saying this OB word. And I'm like, I haven't said anything about, I was like, did I say if she had a kid? I'm like, so confused. And she's like, yeah, that OB word you keep saying. And I'm like, what OB? And I'm like, I'm trying to go fast. And I'm like, what's she talking about? And she's like, and then I realized that she was talking about obesity. She's like, yeah, what's that word? And I'm like, oh my gosh. Like how are we going to get started? She has even no idea that I don't think of obesity as a big word. I don't think of it as a word that most people, I assume, will understand regardless of, education level, but she had no idea what I was even talking about. So I was like, so then I tried to explain that, struggle with weight or carrying more weight. And she's like, oh no. And I'm looking at like her family and I'm like, she has no concept. So if we have to first get them to understand that there is an issue and then get into this idea of like, okay, well, let's influence my weight based upon maybe breastfeeding and other things. But so I don't think they're thinking about like, oh, I'm hungry. And so I think we're so far behind that. I also had another woman bring in her mom to the emergency room. I don't know, I have a lot of stories in the emergency room. Somebody needs to do a study on that. But she brought in her mom to the emergency room. This was a young woman who was similar age to myself. And she brought it in. She's like, my mom's too big, blah, blah, blah. She needs to do something for her health. She was brought in for what we call obesity hypoventilation syndrome. So her breathing was being affected by her excess weight. And I'm looking at the daughter who struggles with severe weight herself. And so I asked her, I said, I am worried about your mom and her weight, but do you mind if I ask how much you weigh? And I'm going to quote her directly. She was like, well, I'm 292 pounds and I am sexy. And I said, well, I can't, in the medical term, they didn't teach me what's sexy or not in medical school, but I can tell you that regardless of that you're still struggling with severe obesity. And I'm concerned for you just as much as your mom, who was bringing body, and her mom was about 318 pounds or so. But she's not seeing that her weight and her body mass index was in the order, because I calculated it, of course, was in the order of about 60. She didn't see that as problematic. So I have to at least start there. Yes.
And I would also add that same definition to our babies. So often we see moms tell me, but look at him, he's big and plump.
Exactly.
You see it, so
It's good. It's good. It's good. It's not seen as problematic. And so we have to start at the it's kind of like the building blocks, right? Like we learn to our ABCs before we learn to read. And if we haven't even gotten persons that are Latino, right? So that's very common in the Latino population or the African American population to even begin to think about weight and weight regulation. I have to go. This is my cue. I noticed this. Is where we have to start. So hopefully that helps understand. I can always talk about this later. Thank you guys so much for having me. I appreciate it.